Look, emergency shines is the topic of this session, and I think we can proudly say that it absolutely does. Every year, New South Wales Health has 2.7 million patients in our emergency departments, and despite this, we continue to deliver truly world-class care to all of those people. But I'd like to acknowledge, and Norman's touched on this, that for emergency departments to shine, there is a large amount of work to be done behind the scenes. Hospital wards to ensure patient flow and discharges in the community to keep people healthy. In ambulance services, both our non-emergency patient transport fleet and New South Wales Ambulance, to ensure our patients are getting the right care in the right place at the right time. So as Norman's also mentioned, we do have targets for our emergency departments, and one of those is for our ambulance colleagues to offload patients to hospital emergency staff within 30 minutes, and that target is 90%. We've just come through the peak of our winter season, and it's been a very challenging and busy winter period. In an emergency department performance, we do very well in comparison to other states, especially in areas of triage, where we lead the country. This year, we've had two main areas of focus. Transfer of care, the timely offloading of ambulances in our EDs, and emergency treatment performance, which is to see, treat and discharge patients either home or to the wards within 4 hours, and that target is 81%. What we're going to be talking about today in part is the huge transformational change across the system and the outstanding improvements due to the hard work of our local health districts, non-emergency patient transport and New South Wales Ambulance to improve our transfer of care performance. So we've got Deb and Paul from RPA, who will touch on this in a moment, and Paul Tonge from New South Wales Ambulance, because I think that you'll agree with us that our improvements have been outstanding. For example, over the past 6 weeks, there have only been 6 days where the state hasn't met the target of 90% of ambulances being offloaded in that 30 minutes. So look, you'll see from that it's fairly self-evident. I'm very pleased to say that the green line is 2016, and that indicates the 90% transfer of care target. So you'll notice there that each year in August we really do dip down, and throughout the year we also had struggled in previous years to get anywhere near the 90% target. And because of the work that we've done, and I think that if I could bottle this somehow and capture the way we've gone about this, we'd have the cure to a lot of things, but the guys will talk more about that. It really has been achieved through a whole-of-system approach. The other target, of course, as I mentioned, emergency treatment performance, is a very important target, and there is good evidence as to why patients should spend 4 hours in our emergency departments. There is also good reasons sometimes why they should spend more than 4 hours in the emergency departments. In 15-16, we were able to assist 45,000 additional patients through our emergency departments within 4 hours in comparison to the previous year, but we still have more work to do. And the focus on improvement, certainly we are looking at the moment, is looking at discharge in a more timely fashion, shifting it to earlier in the day, and increasing weekend discharge so that we can operate as a true 7-day-a-week service. And we have Ray here as well, who'll talk about some of the exciting times ahead. Ray, not to overbill you there. And the focus of our next 12 months, obviously, is to improve this target further. So without further ado, I'll ask Deb and Paul to come up onto the stage.
So coming up on the stage are Deb Wilcox, who's the General Manager of Royal Prince Alfred Hospital, and Paul Torzillo, who's Clinical Director of Critical Care and Executive Clinical Director of Royal Prince Alfred Hospital, and also Ray Messam, who's Executive Director of Health System Information. And we're going to have this seamless passing of the baton, are we? Are you going to do it from here, or are you going to do it from there?
Oh, what would you prefer?
Whatever you want to do.
Well, I might make a few opening remarks if I may, Norman. Thank you. Good afternoon, everybody. Thank you for inviting me to speak. I'm Deb from Sydney Local Health District. I'm the General Manager of Prince Alfred and the Director of Operations for the district. we're no different to any other district, any other acute hospital in the state when it comes to emergency departments and pressure. I've been in my job now for about 3.5 years, and when I first started, they tell me a busy day in the ED was 160, and in recent months I haven't seen a day under 200. We had a day we cracked 272 one Sunday this winter. So our problems are no different to anybody else, and we always think about winter, what worked last time, what can we do this time, what do we need to tweak, and certainly our minds were focused when it became the Premier's priority and the Minister's priority and then the Ministry's priority, and so definitely it became our priority. We were obviously very involved in the Peak Activity Task Force with Susan Pearce, and I think that focusing of attention of the whole system was really, really valuable. It meant that we all understood everybody was experiencing the similar issues, and we could pick each other's brains either formally or informally. Now, we've tried to replicate some of that at Sydney Local Health District, and I guess there's sort of 3 parts to what I wanted to talk about today very briefly. Firstly, we continued to do our whole of hospital program activities, and as I said, we tried we continued to implement our winter strategies like extra pharmacy, extra allied health and the like. But we started a daily emergency treatment performance teleconference. It was chaired by Teresa Anderson, the Chief Executive of our district, and everybody is on that teleconference. In fact, they're still running, and we're going to keep it going because it's just worked so well for us. So it's all of the general managers of all of our hospitals, all of the managers of our services, including aged care, hospital in the home, mental health. The performance unit joined us, NEPT coordinator joined us. So it was a large group of people, but it was such an important personal and professional interaction because, again, everybody's hearing everybody's story and situation, and then people are saying, hey, hang on a minute, we can do that. Well, hang on a minute, there's a compact still available. Why don't I ring the rehab, And it got this really good discussion going. So we sort of cracked a whole lot of problems, sometimes only in a 10 or 15-minute teleconference. So it's been a really useful experience for us and one that we're going to continue to do. The other important thing is obviously data, and we've been very lucky to have a ClickView application called STARS, and that really allows us to very much get very detailed information about performance of each facility, each ward, and right down to clinician level. And that enabled us to be very quick to make decisions. We could think about the day that was and say, well, Concord, RPA, what went wrong yesterday? Why was things so difficult? Was it a problem with the lift? Was it a problem with rehab? Was it a problem with NEPT? And if there were things that we could fix that day to prevent it happening again, we do it. Some things are a little bit harder and take time, but it really enabled us to move with the times and get ourselves sorted. And some people in the room I know have been into my office. The Chief Executive does like to torture me. I have 4 large TV screens in my office. I glow in the dark, and the patient flow portal is on 3 of them, and the ambulance, my colleague Paul's dashboard, is on the other. So I can watch the ambulances filling up at RPA and watch the minutes ticking over and say, come on, and ring down and get all worked up. So that's a very useful tool and allows me to be, and the Chief Executive and other members of the Executive, to be right on it. Operationally, we put on and none of these are sort of brilliant ideas, so to speak, and some of them are quite bland by term, but have been very effective for us. We have an ETP coordinator, and the person we had doing that was the nurse manager of our intensive care service, and that was a conscious decision because of where the ICU sits in the hospital and how they interact with the wards, theatres, radiology. They know everybody and they know how the place works. And apart from that, Adam Reid is a really nice bloke with a great temperament for when things get a bit hot, when you've got to ring and hassle clinicians to do around. We also put in an NEPT coordinator because the NEPT system is obviously improved considerably across the state, and they're incredibly responsive and helpful, but we found having someone of our own to help escalate and broker any issues around that was really useful. We have twice daily bed huddles and a little initiative called Priority Discharge Protocol, which I might just mention, go through in a little bit more detail in a moment. And then, of course, the other bit is how we involve our staff and how we keep them, when they're fatigued, it's winter, patients keep coming through the door, the grind is pretty tough. So we, again at Teresa's intervention, we established a program called Winter Games where we did some point scoring, and I'll just show you a little slide on that in a tick. We also continue to respond to the staff. So every day we get the reports, we'll be in the car, 6:30, ding, ding, ding on the email, they'll all come rolling in, we'd have a look at the results, and before I got to work, Teresa had already sent out an email saying, well done, you bunch of legends, congratulations, just so they knew we were, watching in a positive way, not watching in a creepy Big Brother way. And visibility. As much as possible, we try to be out and about. So in the ED, talking to people, so they get a sense that we're actually with them. We're not just sitting over the road and I'm watching the screens and not really connecting with them. So I think visibility has been very important. That's a really horrible slide to look at, but I've deliberately picked it. Paul and I thought it was a good one because it's really busy, but it shows you that that's every day we tracked the ETP. It's only just one version of the data we collected, and that's for each of our acute hospitals. But it means every day we watched everything that was going on, and as I said earlier, could unpick any little bits of that to understand what we had to do to do better. This is the Winter Games. So this was a competition whereby you got points, and we included mental health and HIF and everybody in this. It wasn't just the acute hospital, for initiatives and improvements, turnaround times, patient flow, a whole range of markers. And so apparently the chief is giving us a big pot of money to do something. We're yet to see that yet. Promise hasn't come good just quite. And with my with my RPA hat on, the only thing that's really relevant in that slide is that RPA's beating Concord. The last slide, and I won't spend too much time on this because Paul, our colleague from the ambulance service, is here, but this has got to be one of the most really fantastic changes in a model of care that I've been involved in. And you always know when the CE comes back from CEF with an idea, it means work. And it'd be fair to say some of us weren't too sure about this, and we've been completely proven wrong. The relationship, and I won't talk fully through the model, I'll let Paul do that, but basically as it states, and many other districts do a similar thing, is about the nurses taking over the care of the patient so the paramedics can get back on the road. And the one thing about this was that the common purpose of this made it really easy to implement. It was the fact that we all understood that the patients who are at home waiting for an ambulance, or the loved one that had dialed 000, were the people that were really, really the most at risk, and the people that we needed to get to. The person in the emergency department at RPA is surrounded by some of the most incredible clinicians. They're being watched and cared for. So the aim of this was to get the paramedics back out on the road. And these figures are quite remarkable. Obviously the art team business is finished, but look how much we fell. Our TOC went up by 22% at RPA. Overall the district went up 16%, and we gave back to our paramedic colleagues over 2,000 hours on the road. We went through a careful methodology, we took our time with it, but we actually introduced this in less than 2 weeks, and that needed equipment, the new trolleys, additional staff, protocols to be written, so there was a lot to do, but we just were methodical the whole way. We evaluated, we risk assessed, again we were visible, we were down in the ED every day checking if there were problems and responding to them quickly. We involved the union. It was a really, really good process. But I guess the results speak for themselves, but the relationship with the ambulance service is just my last comment. We have the most tremendous relationship with the ambulance service. And for me, I feel like they're just part of the gang. I don't even separate the two anymore. And we've had a great team that we meet with regularly. And it's not just the good coffee in Newtown is why they like being with us either. So that's pretty much all I needed to say, I think. I'll hand over to Paul. Thanks very much.
Paul Tong, who I forgot to introduce first time around. Paul.
I snuck up onto the stage. Please don't apologise. Thank you for having me and the opportunity to speak to you this afternoon, ladies and gentlemen. Firstly, I'd like to apologise on behalf of our Commissioner, Mr Dominic Morgan. Unfortunately, he's been detained on another matter. I have a few slides to show you and speak to. Unfortunately, Deb, I won't be going over the TOC model. We must have had a bit of a miscommunication there, but so am I pressing the wrong button or? Oh, back. Here we go. So I think the most important word in this initial slide is partnership. Okay, we've heard over the last couple of hours about some very, very impressive programs that are going on at the moment involving the ambulance service and essentially assisting us with demand management because we certainly have a challenge in that area which we've experienced over the last couple of years in particular. And I think the more we work in partnership with our health colleagues, it's about two things. It's about ensuring that we have an ambulance available to respond to the next 000 call, and it's about the patient. It's not about a number, it's not about a KPI. It's about what's best for the patient and our ability to get there. So what we saw from the initiation of the Peak Activity Team project in September last year was a significant improvement in transfer of care performance across the system and across the state. This was helped most certainly by the TOC project at Royal Prince Alfred Hospital, which was a hospital that we were sending ambulance release teams into on a regular basis. Our ambulance release teams were 2 paramedics, staffing a vehicle with 3 stretchers that would go in, transfer the patients to the ART team's care, and then thereby release our resources. Between 2013 and 2015, in August and September, we had rostered roughly 15,000 hours of ART overtime. So you can imagine the cost of the system of that sort of impost. From September and the initiation of the Peak Activity Team and the Peak Activity teleconferences, the requirement for us to roster ART dropped off a cliff, I'm very pleased to say. This gave confidence to the system, which allowed us to decommission the rostering of ART from 1st of March this year, which was an incredible improvement and something that was considered by many of our staff as to be incredibly brave. A brave decision, I think, yes, Minister says. So what we have seen is, with the improvement in transfer of care performance this year, that we have not needed to fall back on ART. We have seen an improvement in our 000 response performance, but importantly we've seen a 15% improvement in our response performance to the cases that are often graded as not necessarily needing a lights and sirens response. And our experience has been that very often those patients are the patients that potentially are a 90-year-old lady who's lying on the floor who just needs assistance to get back up. So instead of taking 2 and 3 hours to get to that person, we're now taking 30 minutes, which is a significant improvement for us. What we found also since September last year is a significant improvement, an increase in our communication and our engagement with our partners in the local health districts, in the hospitals, in the patient flow units, but especially in the emergency departments. And that has benefited the ambulance service in an increase in understanding of our role and the challenges that we face, but also conversely, it's also assisted in the promotion of the understanding of the challenges faced by the hospital system on a day-to-day basis. So in terms of improvements and how we facilitated better external communication with stakeholders outside the ambulance service, on the left-hand side of the screen you will see a screenshot of the ambulance arrivals board. Now this was introduced in 2015, took the place of what was previously known as an ambulance status board. Now, as Deb indicated, this is sitting on a computer desk in her office, and it is also available and utilised by all emergency departments, patient flow units and executives across the state. What it replaced, the advantages of the system that it was previously in place, was it shows the ambulances that are currently en route to your particular destination, but more importantly, and what was mentioned in an earlier presentation, it gives the opportunity by showing the booked transfers on the way into the hospital for intervention to take place, to perhaps discuss with clinicians associated with that patient if a facility is under a great deal of pressure, that there may be an alternative destination for that patient which would be appropriate. We've also taken from this feed, which is a web-based feed, we've also taken that feed and generated automated SMSs which show delays at individual facilities. We're pleased to say that the take-up amongst our hospital and LHD colleagues has been very high. So these are automated to be set at different time frames. So if an ambulance is delayed for 45 minutes or 90 minutes, different members of the executive, the patient flow units and the EDs will be notified by SMS. It also shows when the car has been offloaded. In terms of our internal communication, from March 1st this year, we introduced a revamped escalation flow chart for when our vehicles were delayed in transfer of care at emergency departments. This escalation flow chart involves members of the hospital executive getting phone calls out of hours, but ends with the Deputy Secretary, which was a significant change for the ambulance service, and one we found has been exceptionally useful for us. Our escalation flow chart has been promoted throughout our management group, our control centres and our operational paramedics, so that they're all aware of it. Earlier this year in June, we introduced an application called CADLink Update, which is essentially a Twitter feed between our operations centre managers, our control centre managers and often our health relationship managers who are managing transfer of care delays at hospitals. It was assessed last year during the worst days of winter that we were making up to 20 hours of phone calls to our Sydney Control Centre between operational managers, health relationship managers and our control centre officers, trying to chase up information on different delays and trying to free up resources. This application, as it's been taken up, has cut down the need for that sort of communication and missed phone calls and return phone calls down to just about zero. It gives the information in real time, and as an older person, not a Twitter user, the hashtag thing scared the hell out of me, but I've eventually got used to it. I'd just like to end on give a bit of a bookend to this presentation. You may be aware of this photo. This is a photo of a lady by the name of Francesca. It was an 83-year-old lady who on August 21st last year fell in her driveway at Haberfield, fracturing her humerus. This was about 10 o'clock in the morning. It took us 3 hours to get an ambulance to her. You may be aware that the television news crew got to the location before we did. At that time, 60% of our resources were at destination hospitals in the east, waiting to offload. Our other resources were responding to jobs at the scene or departing for hospital. This was obviously an unacceptable situation and had ramifications and ripple effects across Francesca's family and across the whole system. This photo bears no relationship to the story I'm about to tell you, but when I tell you that story, it will become obvious why. This is just a photo of an ambulance tour of a local primary school of a couple of young fellows. On the 12th of August this year, at 11:06 in the morning, our Sydney Control Centre got a 000 call to a primary school in Double Bay. It was a call to a 10-year-old boy with a cardiac history, collapsed in the playground, receiving CPR. This was obviously graded as a 1A call for us. Call came in at 11:06. Two resources were dispatched at 11:08 and 11:10, arriving at 11:14 and 11:16 respectively. CPR was continued and a single DC shock from the paramedics defibrillator was administered, resulting in a return of spontaneous circulation. The young fellow was transported to Sydney Kids, arriving at 11:45. That night at 6 o'clock he was out of bed running around wondering whether he could run his lemonade stand for City to Surf. My point being, The efforts expended by our local health district colleagues and our hospital colleagues and our ED colleagues in making our resources available for the next 000 call has been profound on our ability to do that. I don't think in 2015 we would have had the capacity to respond in the same sort of timely manner. But this year, with the changes that have been put in place, driven by New South Wales Health, the Minister's Office, has allowed that sort of timely intervention, which leads to that sort of an outcome. Maybe an emotive statement, but that's the facts. Thank you, ladies and gentlemen.
So just remember that next time an ED director complains about the 4-hour rule. And finally, Ray.
Thank you, Norman. It's hard to follow that, Paul, but thanks for the opportunity to speak today. I just want to first comment that when I get up here and talk about a state perspective on dashboards and tools, I think I first want to make the comment that the innovation and ingenuity across all networks and districts is absolutely amazing. And I think we have more than 1,000 staff, and that's a conservative estimate, but more than 1,000 staff with health information, health analytics, and ICT capability, delivering a whole range of tools. And Deb touched on STARS as one of them earlier, and Paul touched on the Ambulance Arrivals Board as another one. But really what we aim to do at the state perspective, for lack of a better term, is steal all your great ideas and scale these across the state. Pick up those little cutting-edge technologies, those cutting-edge nuggets, and really make them available for everyone across the whole system. So I've just sketched a landscape there, which includes the patient flow portal, which Deb has also mentioned, a tool that we're rolling out across the state, which is our operational reports, which sit on top of our new and flashy new enterprise data warehouse. But really what I wanted to mention was the rationale behind doing this is to really enable us to have a meaningful conversation around our key critical indicators, our key strategic priorities, be looking at one source of truth for that information, and to really provide that ability to have a meaningful conversation, looking at not what the number is, but why the number is what it is. So noting all of that, I'll kind of pick up on one interesting new development recently. You'll see up in that picture there the ED Arrivals Board. So I've stolen Ambulance's nice name of the Ambulance Arrivals Board, and we now have a project underway to deliver an ED Arrivals Board. Interesting story that our fine Premier visited Wagga Wagga Base Hospital about 6 months ago, and Murrumbidgee LHD had delivered quite an innovative tool, which really has real time. At the time it was every 5 to 6 minutes, but you could now, I don't know if you're less than that, but every 5 minutes updating an ED type arrivals board, which has a list of patients, their triage category, what they're waiting for, whether it be pathology tests or a bed within a ward, etc., and really providing that information to frontline clinical staff or nurses to act at that moment to really streamline that flow through the ED in a safe way. So noting what I said earlier about stealing innovative and ingenious ideas, we quickly surveyed the whole state and said, how many districts have this tool? Well, every single ED has a source system which provides the basic functionality to be able to do this, but you've got to go back to your desktop, you've got to run a report, you've got to print that off, you've got to go find the patient. So this is really the next evolution. So we found that 3 other districts, Hunter New England, Sydney Children's Network, and Murrumbidgee, all 3 of them had this tool, and it's in place at 9 facilities. We also have been talking with New South Wales Ambulance around the ED Arrivals Board, trying to leverage some of that innovative technology that sits behind that. And partnering with eHealth New South Wales to really get the data behind that dashboard from a state perspective. So Murrumbidgee's dashboard works at the local level, but making sure that the security and the privacy principles are scalable across the state is another challenge. So I'm happy to announce that we do have really exciting work underway. We're taking a user design, UX, they call it, approach to this. So we've got a number of workshops underway with those districts that have the tool in place, and really desiring what's the look and feel of this dashboard, how does it work, how does it integrate with clinicians and nurses, how can we really make this work for the whole state. So we've set a stretch target, and I'm happy no one's taking notes, but a stretch target of winter next year to have this available. Obviously in partnership with, Teresa's taking notes, I see, in partnership with districts, because it's really a collaborative partnership to make a tool like this come to fruition. So we aim to have this available next winter to support all the great work that's, I'm sure, is already in the works. So thank you very much, and I'll leave it at that.
That's great. Now, I noticed from Slido that Bruce Straw has got a lot of questions he wants to ask. Why don't we just take them verbally rather than me stumbling through them? So, Bruce, if you put up your hands, we'll come to you. Are you still here, or have you nicked off? Oh, he's there. Good, we'll come to you in a second. Paul, how do you keep hospital clinicians involved in this? I mean, there's quite a lot of energy that goes into sustaining this process.
Yeah, there is.
Can we get Paul a microphone just before he's off stage? Oh, you got it. You're on. Good.
Yeah, there is a lot of energy. I mean, clinicians are mostly involved at the back end. Exit block for busy ED is a huge issue, and you need to work on a whole lot of things. You need to work on early discharge planning, on attention to discharge, predicted dates, on early discharge, on frequent rounds, engaging the nursing staff, the junior medical staff and the senior staff. And I think you have to do all those things all of the time, and on some days 2 or 3 of them won't work too well and the others will get you through. You have to remember that for most busy hospitals, if you can just find 10 to 15 beds in a morning, that's the difference between coping and not coping. So it's not 50 or 60 beds. So you need to do all those things every day to try and make the system work well.
Including Saturday and Sunday and the golf game.
Yeah, weekend discharges. You won't see me on the golf course, Norman, unless there's been an accident and I've smashed my car there, but so not everybody does. I think that weekend discharges is like the rest of the system. You need to plan for them, you need to have them organised, and if you do that you can increase weekend discharges, and we did that. You've got to engage the senior medical staff if you do that. The way to do that is to talk to them directly. They're busy. The most important high-tech tool for that is this thing. You ring them up, you don't send them emails or memos. If you do that, then if they're like me, they don't delete them, but they never read them. So you've got to communicate with them directly, and they'll get on board with this. It's just a question of working away at it every day.
Bruce.
Hello. Yeah. Sorry, very embarrassing. I don't speak very well, hence why I was typing it. It's mainly just looking at the results, feedback, information that are coming from emergency departments. I myself have actually been admitted 2 or 3 times. The reason the questions looked a bit weird because they were a bit long-winded. So I had 2 questions which were, whilst the care and EDs are excellent and or improving, what's being done externally to prevent and or eliminate code reds, code blacks, the turn away of patients, that sort of thing. We heard of a beautiful story where the young boy was looked after in minutes, and yet at the other end of the spectrum we had the old lady who was lying down for hours and hours.
Who wants to pick up that? Paul?
We don't use the terms code red and code black. They were eliminated in 2006. Currently we have the operation of the patient allocation matrix, and no hospital across the system ever shuts its doors, ever. We have situations whereby each hospital has a threshold through the the operation of the New South Wales Health's patient allocation matrix, which indicates a rough estimation of the number of cars that they can take in an hour from us. We have on occasion selectively manipulated those numbers to give some breathing space to individual facilities, but at no times do we take those thresholds to zero, cutting access for acute ambulances or acutely ill or injured patients into emergency departments.
Can I add something?
Deb, yeah?
Yep.
Sure.
Paul's point about the matrix and the threshold and how we work together is a really important one, because sometimes they do come one after the other. It's just the luck of the draw. And, you know, the way our escalation pathways with the ambulance work is that within minutes a decision can be made that we just need an hour, just slow us up for an hour and send the ambulances to Concord or Canterbury. We work within our district. And it's really very effective, and you just sometimes just need an hour. It's just a processing thing if you're getting them one after the other. The other thing, because neither Paul or I fully described the nursing transfer of care protocol, that really has been a major game changer for us and for the ambulance. So the process is the paramedics bring the patient in, they're checked in, the nurses then take over the care of the patient on a trolley, and there's an ED nurse with them at all times, and then that allows the rest of the ED to be ready then to admit them. So it puts another step in the chain, but one where the patient is right at the nurse station being monitored. Early treatment can begin like OBS, etc. So again, to the issue of it getting really hectic out there for our colleagues, the paramedics, it just gets them back on the road.
And the role of allied health in getting earlier discharge?
Incredibly important. The Minister came and met with some of our allied health clinicians and had the benefit of seeing some of them in action. I don't say this as a suck to allied health people in the room, but I really do think they're the quiet achievers. And it's interesting, people like Paul will do a round when the days are really tight. He'll go floor to floor, each ward, seeing who can be discharged and what we needed to do. And allied health was a standout. Rehabilitation and allied health were often barriers to getting people out of hospital. So they're incredibly important, and they're very innovative and very well published and stuff at our place too.
So, Paul Torzillo, what mistakes did you make that are advice for the unwary? That's advice for the unwary.
I don't think we made
noticed you
any...
shifting uncomfortably when I asked that.
I think we learned. I don't know if we made mistakes. I mean, I think what's important is not taking high moral ground about this. I think if you lecture everybody that they've been doing the wrong thing, they've been being bad, and most of the time they're just working hard doing their job, and they don't spend a lot of time attending to these big picture management issues. I mean, most clinicians didn't do the job to do that. 5% of them did, and most of them are in this room. The other 95% are in the hospitals doing the work that they like. So you need to engage them by saying to them, this makes sense, it's going to make your job easier, your patients are going to get looked after. So you don't take the high moral ground, you communicate with people frequently, you talk to them rather than send them emails. And I think you learn through that process that some things don't go so well. Usually communicating, trying a bit harder, keeping everyone engaged is the way to do that.
So Deb Wilcox, just finally, will this survive you? In other words, how sustainable is it beyond the current leadership team?
Look, it will. It may look different in a year or 2 years or whenever I go and then beyond. But I think the principles will be sustained. And I think the three that I highlighted in that first slide was around communication and governance. If you don't communicate with each other and you don't have some structures in which to do it, that you routinely do it, it will fall over. You come up with good operational ideas, which usually come from the staff, and they'll change from time to time. And some, we've been doing the same thing for 10 years, and some were brand new last week. And then the last is actually working with your staff and being visible. And I think those things are the things that should be sustained, and what sits under them will change day by day.
Susan?
I think it's important to add to that because, and I was joking with Paul earlier, when we've got to remember that this has been for more than a year now, we've sustained an incredible level of performance right across the state. So it's not just Royal Prince Alfred, it's all of our facilities, rural, metro, everyone working together. And so there's a big lesson in that for us because it has been a genuine partnership with everyone who needed to be involved. And when I walked into ambulance to talk to some of the senior ambulance people earlier this year to tell them that we'd taken the decision to remove ambulance release teams from our landscape that had been in place for more than 10 years, I was greeted with a room of folded arms and quite considerable concern, because it was about February and they were very concerned about what winter of 2016 would hold for us. And, you know, we did that in an educated way. We knew that our performance was such that we could remove art. And, you know, recently one of Paul's colleagues, whose arms were probably folded more tightly than others, actually called me to say, you know, we've done it, and that was pretty amazing, wasn't it, Paul? So, look, you know, I think we have done this in a way that has enabled this to be sustained and not reliant on individuals, and that's the key.
Sorry, Paul Tong, just one final question from up there, which is, I think, a really important one, which is, they're all important, but is in this world of integrated care, the healthcare home coming on board, hopefully more GPs equipped, infrastructure-wise, to deal with complex patients.
At home.
To what extent is the ambulance service equipped to actually use the GP as your destination rather than the hospital?
We currently have a system whereby paramedics can refer to out-of-hours visiting GPs if appropriate, and can...
But what about taking the patient to the GP?
This is the beauty of, and this is the point I was trying to make, that the ambulance service needs to work very, very closely with our health colleagues, including the primary healthcare networks, including primary care, to develop those alternate pathways, to develop ED avoidance. We need to do it safely. We've currently got pilot programs working in Western Sydney and Southwestern Sydney for the direct transport of patients to urgent care centres, which are co-located at EDs, and we think that they are precursors to the direct transport of patients to EDs, to GP clinics.
So it's on the agenda, but you've got to have
future.
somewhere to take
Absolutely.
them. Can you please join me in thanking our superb set of speakers? Thank you very much indeed.